Welcome to the Microdosing for Healing podcast. I'm your host, Casey Garrett, and together we'll be discovering and learning from inspiring voices of healers, medicine keepers, and visionaries. Every episode, we'll explore the world of health, vibrant wellness, and natural medicine for a new era of human society. Welcome to today's episode. All right. Hello, everybody. Welcome to the podcast. So today we're off on a little bit different of a topic today, and I am so looking forward to this conversation. My friend and colleague, Alan Wiederhold, is here. He is an author of a new book called The American Illusion: Why Healthcare is Rigged and How We Break Free. So many of you who are listening have been working with microdosing, have been working with earth medicine, and as soon as people get into this work, you quickly wonder, why is this not everywhere? Why is this not known? It's so accessible, it's so natural, it's so effective. Why are we not educated about this? Why do we not have access to that? And that leads us to our topic today. So those of you who have worked with me know I have been in the healing arts for 30 years, completely outside of the matrix. I have always from the start been in the quote unquote alternative realm, and for better or worse, been outside of the system. Today, our guest is the opposite. He has spent 3 decades inside the matrix, inside the Death Star, and brings a very unique, learned perspective to the system we operate in today. So I want to share just a little bit about his background and bio. We'll put much more in the show notes about him because he is an accomplished gentleman. But for more than 3 decades, Alan has served inside America's most complex healthcare systems, leading companies through turnarounds, uncovering hidden revenue structures, and advocating for employer transparency long before it became national policy. His experience as a U.S. Navy veteran and trauma survivor shaped his understanding of how broken the system is, not just for patients, but for people trying to navigate it. Alan's mission today is simple: tell the truth, heal out loud, build systems that serve people, not profit, and help others reclaim their purpose, one conversation at a time. Thank you so much, Alan, for being with us today.
My absolute pleasure. Absolute pleasure.
So take us back, for those folks who are new to this topic, take us back to the very start. Like, how did our current health insurance become invented?
Absolutely. So there's a couple of theories. Bunch of coal miners actually in Colorado, Washington State, and California were needing medical attention. So it was the very first kind of what we call precursor to prepaid medical. So you just paid some money up front, and that gave you access to physicians, to the local doctors. But it really kind of became more formalized in 1929. Baylor Hospital created a prepaid medical program. You paid 50 cents a month. It was primarily for the teachers in the area. 50 cents a month, so I think it was $600 a year, gave you 21 days of hospitalization policy. It's actually what we know as the Blue Cross plan. So it became Blue Cross. But really, if you kind of think about it, it was 50 cents a day, $600, 21 days, because back in 1929, you didn't live beyond that. So it was never meant to really be what it is today because the lifespans were much shorter. So if you went to the hospital and you actually needed to go, you weren't, chances are, coming out of the hospital. So, and if you were, it probably wasn't that serious anyway. And then about 20 years later, we got the other side. So the physicians came in. So as Blue Cross started to grow on the hospital side, we needed something for the physician. So that was really kind of the very first of what we called healthcare or managed care back in the day. It really became part of the employer plan, though, when we were just finishing World War II. So remember, during those times, we had all of these men and women that we were sending out into the war, and then they were coming home and they were getting jobs. Well, the problem with that, though, is how do you attract new workforce? It's just coming back. You offer them fringe benefits. So the very fringe benefits were health insurance. So It actually became a Supreme Court ruling. It was Youngstown Steel had actually challenged the tax code on how this all became an employer-sponsored benefit. So really the reason that it is so embedded now is because employers get deductions for offering health care to an employer, to the employee.
Fascinating. Okay. Okay. Because I have long wondered, and I'm sure a lot of people listening do too, like, how did we ever come to entangle employment with health in this country? Because in other countries, they don't do that. It's
So
your relationship with the
largely because
insured.
of the tax code.
Fascinating. Okay. How does it work in terms of like who actually gets to decide in our current system what gets covered?
So this is where it gets a little bit dicey. So let's kind of back up a couple of steps. So again, we talk about Youngstown Steel, we talk about fringe benefits. We start to see the increase of longevity. People are living longer now. So now we're extending care and it's becoming a little bit more expensive. So if you go back and you kind of look at the 60s and the 70s, we created the HMO Act. So in 1974, we're looking at like all of the stuff and we're trying to figure out how to normalize the cost and how to make people healthier. And Richard Nixon actually proposed the HMO Act of 1974, and it was the very first idea of a Kaiser Permanente kind of model. So it was known as a staff model. So you could kind of go into the staff model HMO if you wanted to, but it really was still kind of an outlier because back in my day, I'm 56, we had an indemnity plan. So you just had a deductible. You paid the first whatever, $500. The insurance company paid 80%. You paid 20% up to a maximum out of pocket. There were no networks. There were no pharmacy benefit management things. There were no copays, no anything. So that's just how it was all the way through the.
Wait a minute. So literally it was that simple, just 80-20.
I actually, it's funny because I have a story, and I don't know if it's from trauma or not, but I was 7. I fell off my bike. I was doing a wheelie in front of a girl's house trying to show off, and I split my chin wide open, like wide. Like it was just like bleeding, and I've got stuff hanging out. And my friends all walked me down to my house. And my mom, back in those days, they were maybe harder, but she made me sit down and finish my dinner. But there was no network of directory of doctors. There wasn't a hospital I had to go to. My mom was like, if we're going to go sit in the ER, you're going to finish your dinner. So we went. My dad never got a crazy bill. That was kind of the thing that stuck with me is he was part of the union, had great benefits, but it was an indemnity plan. Like there was just none of this stuff. Everything was considered covered because you had skin in the game. It was your money and then the insurance money and then your money again.
Got it. So then as things grew, and bureaucracy begets more bureaucracy and layers. One of my big takeaways reading your book, it was just shocking. It was kind of watching the movie that you're like, can it get worse? Can things get more dramatic? And then they do. And you're like, oh no.
Yeah.
And so to see how quickly we've gone from that, which is very largely simple and very sensible, to where we are today. Take us through how that happened and kind of who has been really directing most of these decisions.
I think a lot of it really is kind of competition. So, again, we transitioned from the 80-20 indemnity to some harebrained idea to go to a staff model HMO, and that gatekeeper, your primary care doc, was going to tell you where you could go, where you couldn't. It really wasn't a function at the time of doing what was best for you. It was really controlling cost. So, again, people are living longer, starting to get a little bit more expensive. And that's when we had the idea to move from an HMO model to the managed care model. So you have a network of doctors. So now what happens is at the time, the landscape was littered with health insurance companies. Like you could literally go back if you go back to the 90s and look at all of the players that were in healthcare, Snoopy had a health plan. So MetLife. Principal Financial Group, the Wedge, had a plan. Travelers Insurance. Actually, my first job. I was 19. I worked at the Red Umbrella. They were the largest health plan in the country at the time. gone today. So Great West, Prudential, The Rock. I mean, so it was literally all of these carriers were out there because we hadn't invented the networks yet. So you could still go out. It was still the indemnity program. They were all moving to staff model HMOs where you had the gatekeeper. And then someone had this great idea. Let's just create a directory of doctors. And then we got to go to the doctors and the hospitals and we say, we're building a network. And, if you want to be in this network here, you're going to need the dollar you want anymore is not going to cut it. You're going to need 50 cents. Everyone else is taking 50 cents. And these doctors are all scrambling and panicking because they're not talking. And they're like, okay, where do I sign? So we create these directory of doctors that are supposed to control cost. But how do you do that and tell a hospital that they still need to make money? You raise the price. So you raise the price sometimes 2,800% more than what Medicare allows. So let's just kind of think about, Medicare is the largest purchaser of healthcare in this country. And if they say a procedure is $100, for example, they throw $2,800 on it, and then they give you a 50% discount to make you feel like you got a great deal. There's no rhyme or reason. One hospital can charge whatever they want to charge. It's different than the other hospital. So it's not like you can go to an auto dealer and that same car is the same price everywhere else, and you can haggle with there is nothing. So you have a price that you don't know. You go for services that you don't know what you need. And then you don't get the bill until could be 30 days later, and you had no say on what it was even going to be. Now, here's what gets really, really weird, hard, and almost fraudulent. What nobody realizes is that when a network of doctors goes out to contract with a network, they say, okay, we want the 50 cents on the dollar, but we're going to need a no audit arrangement, which basically says they can bill whatever they want to bill, and the insurance company has to cover it within Blue Cross's 30 days. So in the Blue Cross contract, they have to be reimbursed within 30 days. So you have, and I'll go back again, you have a bill you don't know. You have no idea what it's going to cost you to get there. You don't know what you need. And now there is no auditing of the bill that comes in. So when carriers, insurance companies get the bill, we're like, okay, well, it's a network. We just reimburse.
Unbelievable. I think another of my big takeaways from reading your book was I've always had compassion for doctors working within the system, but I went to a whole new level. And so being taken through from where the doctors were primary and the doctor-client relationship was primary, and to this slowly being eroded over time, to the frustration we experience today going to the doctor. And a lot of people are like, they never told me what this cost. And it's like, well, the doctors don't even know. Yeah. They're equally kept in the dark as well. And the more we peeled into it, I was like, this literally is run like a cartel. Truly,
yeah. It really is. I mean, the national average of time spent with a doctor is less than 6.5 minutes. So they don't know. A lot of things I didn't really put in my book because I could literally have put Epic is the name of a company that owns the employee health records, so EHRs. So when you go into the doctor, and I use my kids as the example in my book because it's one that's just really kind of stuck with me. So anyone who's listening, if you have kids, you go in for the well visits, and those are 100% covered by the plan. But if the doctor actually goes in, like they did with ours, and says, oh, look, there's a little bit of earwax, and then they put the tweezers in there or the extractor tool to pull all the wax out, it then just became a $246 charge because it went from a preventative to a diagnostic. They did something. The other thing that I always find fascinating when you go to the doctor, and again, they don't know, is that if the doctor ever says to you, do you have any questions? The moment that you answer with a question, it now became a diagnostic visit, and it is no longer covered at 100% by the plan.
Wow.
And the doctors don't know. They just go in and they've got notes, or they click. Like if you watch them click, one of the things I would encourage your listeners to say is, okay, you're clicking. What are you clicking? Because you can ask. Because again, with a no audit arrangement, the insurance company doesn't know. I had to call. Fortunately, I live in Maryland. I go to Hopkins. I called Hopkins. We talked to our pediatrician who we were friends with. And she's like, I have no idea. And we're like, well, I need that removed. And then the person in the billing department was like, no, we can't remove them. Like, well, my next call is to the insurance commissioner. I do this for a living. Would you like to remove it now? And it all got removed. So
Wow. Wow. So going back to my earlier question in terms of how does it get decided who gets to
yeah,
decide, because it's clearly not the doctors.
yeah.
The doctor having to choose from what is available versus what a person truly needs. So who are the people that we don't know about that are actually determining all of those things and all those many codes?
So there is a governing body of doctors. It's the Association of Medical. So it's the AMA. So they decide based on research, based on science, what is medically reasonable to be covered, at least on the healthcare side. And then when you look at each individual health plan, we'll look at what is their block of business. What do they see as outliers? What are they seeing from an expense? And if they're getting more of those, they put restrictions on those. So the idea is for the insurance companies, good, bad, or indifferent, is to spread the risk among everyone. So when you go back even before 1929, insurance was really created to protect people from financial insolvency. That's all it was created for. Insurance companies were not created to do what this is doing today. You were going to give it a $10,000 deductible to protect your home and your life and that. But again, no one lived beyond 21 days. So, when you bought a $1,000 catastrophic policy, it was not designed for this. So insurance companies, again, are in business to make money. Whether you like that or not, that's why the industry was created. That's why they exist. But it's gotten out of hand. So they look at what is the most things that they're seeing from a risk perspective because they're in business to make money. So if there's seeing incidences of claims, they have to limit those exposures. And it's all based on actuarial science. So we take what does the doctor say from an AMA guideline? And then don't like to talk about is all the lobbying. So all the lobbying organizations have a lot of influence with goes into our health plans, which we talk a lot about in the book. Between the AMA and pharma and all of the medical related, they spend more in lobbying than defense, schools, and a bunch of other things combined. So they have enormous power with our Congress on how things are legislated, what should be covered and what shouldn't be. And then onto a state level. So the states have a lot of influence as well. So again, I live in Maryland. Maryland has 57 state mandates that go into every health plan. Maryland, we kind of joke and call it a nanny state. So they say that everything has to be covered. So whether it was bariatric surgery, whether it's follicular implants, whether it's things that maybe an employer doesn't need, but because Maryland says we want them to be covered, they have to be covered in a health plan. So again, some of it is risk. Some of it is what is happening at the federal level with lobbying. And the other part is what's happening at the state level. What is the state mandating? Because the other thing that's crazy is that Maryland has 57. New Jersey has, I think it's 46, completely different mandates. California actually mandates by county. So to try to be a health plan or to try to be somebody who administers a health plan and you're keeping track of all this stuff, it's like bananas. But it also adds an additional cost. So again, going back to how do we price? They did an analysis in Maryland, and I think it was like just after, it must have been like 2002 when they started creating these mandates. They said it was about 10 to 12% increase in cost to offer those mandates that they had at the time. Well, again, that was 25 years ago. So take that 10% then, and what is it compounding to now?
Wow. Wow. So our efforts over the years, it's for like increasing every year where more and more people are recognizing this is not working. It's unsustainable, it is dysfunctional, and yet we are so resistant to an alternative and creating a universal healthcare option, separating an insurance option from our employment system. Why are we so resistant to it when we're learning the American taxpayer is subsidizing universal healthcare for foreign countries, but not our own? So it doesn't make any logical sense. Why? Who is kind of lining up against this happening?
Well, I mean, I think we kind of talked about it already. So if you go back, we would have to completely undo the tax code because the employers are getting a benefit for offering healthcare. You're getting tremendous pressure from the big four. So, again, when you kind of look at, there were 57 carriers like 20 years ago. Today, we buy healthcare in an acronym: Blue Cross, United, Cigna, and Aetna. It's BUCA. I mean, anyone in the industry actually knows that. It's an oligopoly. It's a monopoly controlled by a few that make the decisions on everyone else. So we have national healthcare today in Medicare. So 65, whether you're pre-65 or post-65, there is Medicare. There's a lot of fraud. There's a lot of abuse. There's a lot of things that go wrong. But there is kind of the guts of what we have for a universal healthcare system. We also have Medicaid, which is at the state level. Some states participate, some states don't. We have been talking about nationalizing healthcare since Truman. But the reality is that nobody wants to make the first pitch, if you will. And what would that look like? Again, we are a very capitalistic, free economic society, which that kind of goes against what that whole laissez-faire form of government actually was. But there are things that we could do today to actually balance both. You want to know what they are?
I am so curious to know what they are.
I think there's a couple of things. So one, again, we talked about state mandates. So if you were to federalize the state mandates, again, I'm a political science major. I wanted to be an ERISA attorney, so some of the nerd comes out of me sometimes. You could use the Marbury versus Madison clause of interstate commerce to regulate what rebates are. Because if a health plan is being purchased across state lines, it now moves from a state to a federal. So we could federalize what all mandates are and just standardize them. We can say, here's 8 or 12 or 15 or whatever you wanted to do. Even if you said 57, if they're the same state mandates across everybody, we can do that. Get rid of the networks. Just get rid of them. If any of your listeners can agree on one thing, it's probably that customer service sucks for a health insurance plan. I think when we looked at JD Biderider, they do their customer service analysis. I think insurance companies are like 1 above banks and 2 above airlines. Like you're not calling an insurance company because you want great service. You're calling because they've got a huge network of doctors and they control everything. So just get rid of them. They don't really serve a purpose. All they do is inflate price. And if we go back to, again, back in the 70s and the 80s, just to an 80-20 indemnity plan, go wherever you want, you would start to see competition again. You would start to see cash pay. You would start to see direct primary care physicians. You would start to see healers like yourself who now have the ability to open up a business or a shingle and compete without having to worry about all of the other things that are going on.
Fantastic. Thank you. Let's dive into the ACA. Because at the time that this episode is going to be coming out, this is going to be on everybody's lips and in their ears. So the ACA, also known as Obamacare, came out as I'm guessing, a solution to some of these things. And a lot of Americans, currently millions of Americans, participate in this program. I was an early adoptee. I was like, I don't care how dysfunctional this is. I believe in it. Anything is going to be better than what we have. And I want to be the first one. And as a small business owner, it truly has been a godsend. And I hear that from a lot of small business owners who barely use the system. And we give in far more than we ever take out. So we are subsidizing unhealthy people by being healthy. And because I have not had to waste money into high premiums every month, I was able to put that money instead back into my business and create jobs and growth for my community. It has been a godsend. And so I see when all the small business owners are saying, like, this is going to not only affect our health as a country, it's going to really impact jobs in this country way more than people realize. So can you share from your perspective, what is the ACA? What was its original intention and kind of where did we go wrong with that process?
The Affordable Care Act, it was very well intentioned. Again, we've been talking about nationalizing healthcare since Truman. Obama really looked at the uninsured population and said, we need to be able to create a system that's going to allow those who are uninsured to have something. Now, again, most people purchase their healthcare from their employer. We talked about the tax code already, which leaves a lot of other people who don't have access to healthcare. They don't qualify for Medicaid. They're not plus 65. They don't have end-stage renal, so they don't qualify. They're kind of in no man's land. So the idea was we were going to create a state-level exchange program that the federal government would give subsidies to the states to be able to offer an exchange marketplace for an individual to be able to go and to purchase their healthcare. The other thing that was, I thought, really beautiful about it. Now, I actually helped create the Maryland Healthcare Exchange. I created a co-op in Maryland. So, again, in the federal government's genius, they said that we were going to create a new marketplace called a co-op. They were going to be nonprofit. They were going to be able to pop up, and they were going to be able to compete against the carriers, and they were going to be able to take everyone, and they were going to be able to get risk standardization subsidies back from the federal government. Again, it was very, very well intentioned. Unfortunately, it all died in committee. So meaning that I think out of the 50 states that we have, I think there were 26 total co-ops that actually received funding. So if you remember in 2008 and through 2010, we were talking about Obamacare and we started talking about co-ops. Well, what happened in 2010 is that you had to have a loan funded by the next appropriations bill, which I think expired December 31st, 2010. And if your co-op loan was not funded, somebody had put a provision in one of these new pieces of bills that basically defunded all co-ops after that. And they were about, I think, 13 that were in different versions of waiting for money from the federal government to be able to open, and the money never came. So I think out of the 26 that they had the initial investment. They went out to create a health plan. And then again, the health plan was supposed to be able to compete against all of the other carriers. But the way that the legislation read, they couldn't because they were still carriers of last resort. They still were able to receive additional funds. And that's ultimately what happened here in Maryland with Evergreen. So Evergreen was a very successful co-op. They had individuals. They were able to offer a small employer a plan that was really competitively priced. But at the end of the year, they had to write a check for $10 million to Care First Blue Cross, which controlled the marketplace, which basically put them out of business. So after 3 years of really trying to compete, they went into receivership because they weren't able to compete because they had to give money to the other carriers they were taking business from. So again, very, very well intentioned. The problem with every healthcare plan that you look at today, they're not addressing the fundamental issue, which is the cost of healthcare. Everything that we're doing right now, we just put a lipstick on a pig or we put a Band-Aid on something and we don't address the cost. All we do is pass premium on to an employer or to an employee. We can call it a high deductible health plan. And it's interesting. I actually shot a message to Senator Cassidy's team last night. That's like, I read your bill proposal and it sucks. Because it's not going to do anything. You're going to create a Trump high deductible HSA account. All you're doing is you're shifting more money to me to have to come up with an account that's pre-tax. Now, your listeners are probably like everyone else. You're paying for a family, right around the average right now is about $2,500 a month for family coverage for a bronze level plan. So that's a $5,000 deductible plan. So you're going to pay $2,500 a month for the privilege of having a $5,000 individual, $10,000 family deductible. So all in, you're at $35,000 before you ever actually get to use healthcare. So today, people are what I use the term functionally uninsured, meaning you're paying 35 grand and you're getting nothing. So again, it's almost back to that catastrophic idea. Do I just go pay it? Or do I go for the best and stay with an exchange plan, which now we know the subsidies are going to go away? And I've seen and heard 114% increases in some locations in some states. But we're not addressing the fundamental issue of the price or cost of healthcare in all of the services.
Wow. So take us through if the big, beautiful bill that the Republicans passed this summer, if that goes into effect as is, as it looks like it will at this point, with the ACA subsidies being taken out, what do you think is going to be the net result of that once that actually happens?
Well, in the big beautiful bill, there were a lot of other things in there. We took away community health service funding. We're almost systematically trying to dismantle not even ACA. We're just dismantling other parts of the system itself. So I've talked to a lot of nonprofits that are going to start losing funding. I've talked to a lot of community health centers who are going to lose funding. So that's all completely unrelated to what's actually happening. So the Affordable Care Act subsidies are set to expire December 31st. One of the things that you saw with the government shutdown was this showdown of Democrats saying, we really want to be able to have subsidies for the next 2 to 3 years to create something jointly. Democrats don't have a plan. Republicans don't have a plan. No one really knows what to do with this. But Republicans are so against having to have these subsidies. So during the entire shutdown, they said they were not going to take a vote on this, that they would come to the table with something. But really, if you kind of watch what they're all doing, they're all creating programs that are not going to work. They can't decide whether they want to create the subsidy or extend the subsidy, allow it for 1 year, 2 years, 3 years, because we just saw something really interesting happen in the last election. Again, I'm not political. I'm an outsider kind of looking in from a healthcare perspective. We just watched Mikey Sherrill in New Jersey just take New Jersey. So we just saw Tennessee's special election a couple of weeks ago. It went from 14 to a 9% digit. So Republicans are in a really interesting place because they know they're about to lose the next election in 26. So they're at a crossroad. Do I continue to offer subsidies or do I take the position of no and kick the can and know that it's going to potentially cost my election? So that's kind of where we are. But the big, beautiful bill really didn't have anything to do with the subsidies expiring. And we're trying to decide now, what is this new version of healthcare going to look like? Everyone is so intent on killing Obamacare, but Obamacare really never had an opportunity to even do anything.
Thank you. Thank you. And before we shift into our shared love of psychedelics and how psychedelics fit into all of this, I would love to get your insight because I learned a lot. It was exceptionally eye-opening in your book about pharma specifically. Share with us like how, as I opened with, when you start to tap into the healing that is abundantly available to us, and it's like, why? It's frustrating, it's maddening, it's mystifying on so many levels. But the more I read about what you shared about pharma and just the power it holds over our society, our culture at this point is really substantial. So share some of that with us and how we can work within this framing.
So one of the things that the listeners have to really understand when you're looking at, and I almost want you to go out and get a copy of your insurance bill, and I want you to open it because your premium is actually broken out into several places that you may not realize. So there is a layer of protection for the overall plan. So if we know that, let's just say the plan could spend $1 million on an employer plan, there has to be some protection on that $1 million. So there is what's called stop loss or reinsurance. So the reinsurance says I'm going to protect every individual's claims up to a certain dollar amount. And then I'm going to protect the entire group, whether that be one group, 5 groups, everybody that's in a Blue Cross plan, everyone. So there's reinsurance. It's about 15 to 30% of your total cost when you look at your bill. The next are like little slices. They're admin. So somebody's got to pay the claims. They got to answer the really crappy customer service. They've got to pay the tax filings and stuff on behalf of the insurance company. There's the network of doctors. There's the PPO. So there's, again, a little sliver. It's like maybe 2-3%. You have the cost to actually have a prescription card. So right now, if you look at who's on your card, there's 3 primary drivers of pharmacy benefit management right now. And that's Optum Health, which is owned by United Healthcare. There's Express Scripts that actually went into massive $50 billion of debt to buy Cigna. And then Aetna was actually acquired by Caremark CVS. So those 3 kind of make up the lion's share of what we call pharmacy benefit management. It's a middleman, basically. So what happened, kind of going way back to what we talked about with HMOs, is that somebody said, hey, I've got an idea. Why don't I go to the manufacturer and negotiate a price, and then I will inflate that price, but I'll give a rebate on the backside of it. And then we'll grow the formulary list. So you either get a generic or you get a tier 2, which is your brand. And then you have your non-formulated brand, more expensive. And then you have your as drugs got more expensive. We threw you into a 4th tier. And I think some I've seen 5th tiers. So all it really was a manufacturer middleman. They just go and they say to the manufacturer, if you want to be on my list, very similar to the doctors, I'm going to need you to give me a rebate. So let's jack the price of the drug up to here. So that we can bring the cost back down to somewhere down here. But we're going to put you in that tier 2 formulary list. And if you get too expensive, we're going to kick you to the 3rd, but that's okay. So then we started to see this increase of following the money. So when you're looking at pharmacy, right now in that premium that you pay, 40 to 50% of your total healthcare dollars will be prescription drugs in the next 3 to 5 years. So we've kind of cut all the fat out of managed care. So everyone has inflated prices. We know that, but that's not really where the spend is. So it's actually in the drugs. So again, we just saw the very first $4.2 million drug. I talk about this a lot because when you follow the money, you're like, where's my money? So it's in my orphan drugs for those people who have less than 200,000 conditions across the country. We started investing in those. The other thing that people don't realize is that the FDA, while good intentioned, and we've seen all kinds of craziness coming out of the FDA here lately. I voted for RFK as president because of his position on psychedelics. But what is kind of happening there, what people don't realize is the FDA is not 100% funded by the federal government. I think last it's about 46%. The rest of it is application fees from pharma to get their drugs across the line to be able to be marketed. So again, if only 46%, it's kind of like the fox isn't watching the hen house. They built it. So they kind of know where all the screens are. So it's a very interesting relationship. So there are clinical trials that go through. We talk a lot about that in my book. But when you follow the money, there is a lot of disincentives from the federal government to be regulatorily involved. They get their application fee, yes, no, goes to AdCom. And we saw this last year because you and I are in the psychedelic space. We've talked about our journeys in the past, but I was on the Hill last year as a PTSD survivor, as a Navy veteran, trying to get Lycos across the board. The problem was that when you went to the FDA AdCom hearing, they have a process laid out. They have their phases. We got breakthrough designation. And when it got to the AdCom, they started looking at the 3rd tier clinical and they started to question. Now, again, the problem that the FDA has when you're talking about psychedelics is that a lot of times we're talking about assisted therapy. The FDA is not in business to regulate assisted therapy. They are a clinical efficacy, does the drug work with no adverse reaction? So I knew kind of going into it that it was an uphill battle because they don't evaluate assisted therapy. We were asking them to do something that they were not equipped to do. So strictly looking at the measurements and the efficacy, they were too closely tied. So I as much as I hated to see that it pushed us back, I knew that it was going to happen initially. So then when you start looking at like prices of drugs, again, we talk about that 30 to 50% of cost. So Humira actually went off patent everywhere else in the world in 2019. It didn't come off patent here until last year. Why? Because the US uses 20% of the drugs and we pay 80% of the cost. The rest of the world is completely inverse. So what they do is they fight behind myriads of patents in the US, and in other countries, they will buy that generic version and they will shelf it so that it never sees the light of day. AbbVie is probably one of the biggest offenders of this, and they've done it all the time. Now, the good, bad, or indifferent is you're now seeing them in the psychedelic space. They made a large investment into Gilgamesh. which is creating their own version of psychedelic assisted therapy medication. But pharmacy really, when you look at your total bill on your plan, they are right now probably the largest driver of what's going on. And then when you get into the transparency, because this is really the problem we have in healthcare, no one really knows what anything costs. But the federal government said in 2021 that we have a legal right and obligation to know where all the money is under the Consolidated Appropriations Act. And we talk a lot about this in my book. So when you look at those prescriptions, you're buying it at X, you're getting the rebate back on the Y to stay on the formulary, but no one knows where the rebate goes. So the carrier gets it, the third-party administrator gets it, some cases the insurance broker gets it. And then there's also what's known as spread pricing, which basically says that I buy my drugs, let's just say $5.21. I'm going to mark that drug up because you don't know that I spent $5.21 on that drug. So I'm going to mark it to 43, and you're never going to know what the actual real cost was. So we call that spread pricing. And most of these spread pricing contracts are in every carrier. They could have 400 different contracts, depending on who the employer was, depending on what the broker coalition. So insurance brokers go out and they put their own deals together and they load their money and everyone loads their money. So we kind of equate it to just a bunch of vampires who are sucking on the body and taking all the blood out.
See what I mean, everybody? It just gets worse with everything. So that brings us to the topic we share and the field we love, which is the psychedelic field and earth medicines, plant medicines. How do we entrain the two of those things together? Are they actually best served not being together? Let's dive into that. But first, I would love for you to share with listeners how you came to psychedelic medicines, because I find it always very, very meaningful when we're talking about these subjects that it starts with a very, very personal story always. So please share that with us and kind of what motivates and inspires you to really devote such a large part of your life to this work today.
So I was very fortunate. I was very successful in sales. I built a very large insurance company. So again, 30 years inside the beast, I built the system that see today. I didn't know, and we didn't know, any of the early people who created healthcare didn't know it would get this bad, but it's at every stake. So I built this company, and in the process, I got lost. I was very, very unhappy. It didn't matter what I had. I had boats and planes and cars and stuff. And my wife said to me one day, and we talked about this before, I love you, Alan. I'm not going anywhere. College sweetheart, I don't love you anymore. I'm not in love with you. You don't love yourself. You're just miserable all the time. And I remember talking to my doctor, who was my chief medical officer. And we were sitting down at breakfast, and it was my wife and he and I had these friends that were going to these retreats that were, I was part of a mastermind of other business owners. They were just having these incredible experiences and reconnecting to themselves and all of this stuff. And I remember saying to him, no, not going to happen. I went to Bible college. I was in the military. I grew up in a Christian home. They were all drugs. You guys are just a bunch of druggies. I heard about like the 60s and LSD trips, and you guys are crazy. And my doctor said something to me that to this day I'll never forget, and I applaud him. He said, dude, I give you stuff from a lab, probably from China, that I have no idea where it comes from, and you take it without question. But you're questioning something that God created in the ground, and you've got a problem with that? I didn't have an answer. So all of these years of this framing and this stuff, I had no answer. And my wife, God, thank her every day, she had the courage to say, I don't love you. Because that takes a lot of courage for someone to say, because you don't know the outcome. You have no idea where you're coming from there. And she bought a journal. It was called The Year of Us. And I love telling this story. And we would sit down with it every night. It was a 365-day journal that we had to ask each other the question. And then you had to be completely honest. It was the 6th week. And I had, what's the biggest secret you've never told? Now, I said this on my interview this morning, and I'll say it to your listeners again. If you've never asked anyone that question or asked yourself that question in the mirror, go do it. But you have to be honest with the answer. And without even thinking, I blurted out that I was sexually abused as a child for 2 years, every week from the time I was 5 to the time I was 7 by a family member. And then he just one day disappeared. And I didn't realize that moment, everything came out. All the shame and the guilt and the fear and the anger. And I just like, and she's looking at me like, never heard the story. Now we've been together for 22 years and never heard the story. My parents never heard the story. 56 years old. Just shared the story 4 years ago. So it just created this almost avalanche effect of now I've got it out there. What do I need to do? My friends are having these incredible experiences over here, and I and my wife reluctantly go. And I got to revisit my trauma, and I got to confront my abuser in medicine. I got to see a fight with my mom and dad. I was 4. My dad had bounced a check, and my mom had called him everything under the sun, and I was scared, and I was crying, and he was crying. And I asked him why he put that on me, because that's what shaped every thought I ever had about success. Everything that I was trying to fill was an argument that a 4-year-old saw that he didn't even know. So I'm cruising down the road 6 weeks after. My wife and I are connected and things are great. And I hear a voice in the car saying, you know what you need to do? And I'm like, who are you? And no, I'm not doing that. And like, you have to find him. You have to forgive him. I'm like, no, that's not happening. Like that, there's just no. And in my experience, the third time I was in the room, he was actually crying, telling me that it was done to him. So it at this point now shifted how I thought about my own victimhood, because I now was able to reclaim my power, but then compassionately look at him differently. And I did find him 6 weeks later in that car, in that voice. I found him on Facebook, and I called him the next day, and I confronted and I forgave him. He deflected initially. And then as we got to talking, I got to say that I'm not here for you. I'm just here to tell you that I am finally going to be okay. He died 5 months later. He had liver cancer, and I didn't know that. And my mom and my dad, as I'm kind of sharing my story now, had all the same guilt feelings. Oh my God, we couldn't protect you. And I'm like, stop. Like, just, can we stop? My mom called me in October, and she's like, I just wanted you to know he died. But he knew when I forgave him that he died, and I started crying and started trying to figure out like, why, like, what am I crying about? And it was because I don't know whether he got to forgive his abuse. So as I'm diving into plant medicine, I have this incredible healing. I go and I learn everything there is to know about plant medicine. Like I have this, like, when I get into something, I'm like all in. And my mom said, if you ever buy a plane, you're going to, and I ended up buying a plane. I love to fly. But I kept seeing the same things in the same men that I was working with. So I started working with other men like myself, entrepreneurs, type A personalities, what we would call an alpha. Like, I could identify with them, and I knew what they were going through. I had done all the other things. I'd ran 100-milers. I've been to Navy SEAL boot camps. I've done everything to feel something, but I didn't have that connection. So as I'm coming home and I'm learning and I'm getting more into plant medicine and seeing healing, my old life doesn't really work anymore. Like I've been inside and I'm cheating people and I'm creating these systems that I'm robbing them from, and I can't really do it anymore. In October, I left the industry. Like I couldn't. And out of my hurt and my anger, like, the people have to know where the money is and that what laws are already on the books they could take advantage of, be able to take their healthcare back. Because people don't realize that in current legislation, and I'm not advocating that anyone sue, because that is not at all what I am about, but that in the current laws, every employer has to be able to have a documented process of why they chose the health plan that they did, and no one does. Most brokers have not ever shared what dollars they're making. The law says they're supposed to give them every dollar disclosed, every marketing dollar, everything. I should be able to walk into my employer's office. And again, I'm not advocating that you do this. Go into my employer's office and say, I would like to know why we picked our health plan. And they're supposed to have a whole checklist of things that they're supposed to keep on file to do that. Now, going back to plant medicine, I think I heard a number of like 46% of executives and owners of businesses, they end up leaving their old lives because of plant medicine. So some of that is by design, some of it your old life doesn't fit. But now I'm like looking at where we are as a society. And if you look at the US history, and I think the problem that most Americans have is we don't like history. We really like it here, we like it now, and we want to be fed immediately. We don't really want to go back and do the work. So if you go back and you look in the 60s, plant medicine was everywhere. The government was actually doing testing in the 50s. And you and I have talked about this before. So Nixon's administration says, wait a second, I've got a war going on. I've got people who are now waking up and they're not looking to fight. They're looking for peace. There's no money in peace. There's like zero profitability in peace. So I need to control the population. So Nixon's aide says, actually recorded, how do we control the population? Well, we make it illegal. We now victimize drugs. We take marijuana from the African Americans who were at the Black Panthers and their organizations. And then you take away LSD and psilocybin from the people who are starting to wake up and question everything. That's how we got here. That's why it's a Schedule 1. It's not because it doesn't fit medical anything or whatever they want to tell you, but no one is willing to go back and do the work. So to figure out actually why. There used to be science and religion were so closely tied together. And then we just started to see this separation. Descartes, I think, was one of the first where we started to really villainize religion in the place of science. Science kind of became our everything. So in the US, if we don't have a scientific reason for something, we dismiss it. There's no way that enlightenment can actually work. There's no way that your brain and your body and your consciousness could heal itself. We need a pill. So the first problem we have in the US is that we have an instant gratification problem. The second one is that we think science is everything. And the third is we believe whatever we're told. Now, when you look at that from a pharma, we are one of 2 countries in the world that can actually direct to consumer advertise prescription drugs on TV. So think about when you watch something on TV. How many drug ads do you see? Subconsciously, you need that. So doctors have to see more patients to make what they did before. Rep just came in, and we've made a lot of that really kind of challenging, not like the old days, they just come in and give lots of stuff away. But the drugs and the TV and the media and people not questioning why. So they're willing to be okay with being sad, being anxiety ridden, being depressed, because they really are afraid to reach inside and do the hard work, to really start to identify what they are from their ego. Now, again, I'm approaching this from insurance, as a psychedelic facilitator, and somebody who built the matrix. So the reality is, and I see this even with my 11-year-old daughter, we don't want to feel the feelings. So, because that requires the hard stuff. That requires us, Byron Katie says it the best in doing the work. Is the story the real story, or is it around the corner, 2 blocks over and around the street? We don't really want to know. Just want to be able to take a pill and feel better. So I, building the matrix, will capitalize on that all day. So, and that's kind of what you're seeing. Now, again, I left the business in October. I was hell-bent. I created Neuma out of ketamine therapy. So I was working with people in plant medicine. I started to see this incredible neuroplastic effect. That's the beautiful thing about plant medicine. Whether you like the science, you like the enlightenment, the reality is it rewires your brain. So, and you now get to go and learn new things, new patterns, new habits. If you work with someone like you, who is going to work with someone. The challenge that you and I talk about as well as Monday comes. We're setting up psychedelic retreats and therapies as this wonderful thing. There's no magic in mushrooms. You're the magic. You're the one who does the work. They just lower the default mode network to allow you to see what needs to be changed. And it's people like you who are helping with that. But we're selling these things as you go trip and everything's going to be wonderful and it's a one and done. Well, the US population has some challenges with that because I either love science or I love religion and I don't like both. So I work with a lot of clients who will say, we're very clinical. There is no religion in this. We're not talking about the God guy. We're just all they all eventually find their way. It's almost like this bell curve where everyone kind of gets to an inflection point and they start questioning, why am I here? But today we have to look at it from a clinical medical model, because that's what that's what consumers trust. So I've been very involved in the psychedelic space, as you, with Neuma, and I got a call from an insurance company saying, "Hey, we hear you're the guy." Now, I've heard that my whole career. You're the guy to take us from something. And I'm like, no, I'm not. I'm not the guy. And I'm sitting at a Psychedelic Medicine Association conference in DC, and I'm with all these incredible people, and they're all talking about plant medicine and ketamine and all of these things that we know the results, we know they work, but nothing's being advanced. And I look over and I say, you realize that nothing is going to happen until insurance covers this, right? And they were all kind of like, looked at me like I had two heads. I said, unfortunately, whether you like it or not, that's how our US system works. So I said, I'm going to do it. And they said, what? I go, I just got recruited to an insurance company. They know about my other company, Neuma. They love the work that I'm doing in plant medicine. They love that I'm on this mission of healing and blowing up our health system. And I am now the president of an insurance company, and I created the very first ketamine reimbursement model. So that's actually going to be covered under a clinical medical model. Crazy.
Okay. So if I may, I'd love to play devil's advocate
Absolutely.
a little bit, because I know that, especially the past few years in the field, there has been a lot of emphasis put on the science and the research proving that psychedelics work. Although nature may or may not care to be proven out to us at this point. However, and everybody is greatly disappointed when, the latest microdosing study comes out and it's inconclusive, and everybody is sad about this. I am secretly clapping and cheering, because I know as soon as science, quote unquote, proves that it works, guess who's going to move in to capitalize on that?
100% agree with you. So devil's advocate and I 100% agree.
And I feel like there is a force out there that is slowing it down, and all of the obstacles and all of the things we lament, and this didn't pass and the FDA didn't do this, in a way is protecting this work. Because frankly, I don't want Cigna in charge.
Yeah.
I don't want Johnson & Johnson in charge. I don't want all of these tech people, investors, leading and holding the medicine.
Yeah.
So I have very mixed feelings about, I kind of enjoy this moment that we're in. As frustrating and weird that it is I don't know that putting something so pure and natural and sacred inside a system that's so toxic is what actually best serves this field.
100% agree, was really a lot of why I wrote my book. I want to blow up this system. So, again, if you know where all of the money is, where all of it is, pretty easy to now start to create change. But the challenge we have with that is who? Like, who's going to do that? One individual, I'm not big enough. It only takes one to question my employer to ask, do you know where your money is going? And I remember when I started writing this, I created a full field manual and I gave it to an HR friend of mine who has 2,000 employees. She said, oh my God, I never knew about any of this, but I don't have the resources to be able to do anything. So I'm just going to wait till the lawsuit comes. It's insane. But if we were to blow all that up, we would stop seeing, and again, I'm not naive, I've been doing this for a while, we would see the slowdown of the investments of the things that they think they can capitalize in on the backside. I am 100% agree with you that plant medicine has no place in the medical establishment. None. But as a society where we are and where we have been trained and led, people are not going to be able to have healing on a massive scale until we make them feel comfortable. It's so crazy. Again, we talk about this delineated line where you eventually wake up and you move from the science to the enlightened. I see it all the time. A lot of men that I work with are like, well, just like I said before, I don't want to talk about God. I don't want to talk about spirituality. Just seen the studies. And I'm like, okay, we'll go there. Because I know in about 6 weeks, we're going to have a completely different conversation when you see them. So, and it's like, all right, we'll go there. It's totally fine. Like, because you're going to get there on your own. And that's what I mean. I think right now as a society, we are not woken up enough. We're still being played by media. We're still being played by the government. We're still being paid by broker Joe around the corner who's getting paid by the insurance industry. But until we can eliminate all of that, we have to go with what we have, be able to bring healing to at least some of those who would not have done it any other way. Now, again, I go back to myself. If you would have told me, and it took my doctor challenging me on how I was getting my testosterone, like I never thought about it like that. I was conditioned like everyone else. So I'm suggesting we play the cards we have right now so that if we can use the medical model to wake people up, so they start questioning things, which advances the cause to what we all want. I think that's kind of what I'm saying is let's just use what we have right now, which is why I created this ketamine model. We know that 35 million Americans are walking around with MDD, major depressive disorder, and general anxiety. It is inaccessible right now. Psychedelics, whether that be LSD, whether that be psilocybin, MDA, they're still Schedule 1. So I have a ketamine drug that, again, don't necessarily agree with, disagree. It's a Schedule 3. Why? Because we don't reclassify drugs. That's why. The indications are there. We know it works, but because the FDA doesn't go back and reclassify drugs, it's going to stay Schedule 3 forever. So I suggest that we take what we have, let people heal, and let them and all of us advance the cause together. Because again, there will be a shift once you wake up.
Beautiful. Yeah, I think going back, I was talking to a friend in the field the other day about, looking at the MDMA, the path of MDMA and the FDA, and like going back to when years ago, Rick Doblin, stepped into the field and he was like, wow, I want to make this mainstream. I want to make this accessible and I want to bring this into the system. Versus at the time, there was already a vast mycelium of underground MDMA practitioners, many of whom were therapists, many of whom were in the healing arts, many of whom were women, already doing this work effectively. And so I look at now in hindsight, what if we had listened to them? What if we had built on that foundation that was much more organic and client-centered rather than trying to put it into the hands of the pharmaceutical company? What if we had kind of come from the other angle on that? So I would love to see going forward both and, because I totally agree. Everybody who works in corporate in this country, a lot of whom do, and they're getting their insurance through their employer. You're right. I see a whole lot of people are only going to come to this work through that. But also, I hope we can hold out space in this field to come at it from the other angle too.
100% agree with that. Because again, I work with a lot of other entrepreneurs outside. So being in the matrix and out of the matrix, that's an interesting walk. But I see that. But I see the inaccessibility because of cost. The average ketamine was, for example, it's $10,000 a year. And most people don't have that because they're already paying insurance premiums. They're already functionally uninsured. So how do you create a program for them that revolutionize? And when I brought this to several of the players in the field, they're like, what? We're not giving people drugs. And it's like, again, you're competing against this narrative of history that people haven't done the work. I love the MDMA story is so beautiful to me. And I was actually just sharing it this morning because people didn't realize we had actually used it for marriage counseling for decades. So like the practitioners were getting it done and marriages were being solved. But the problem was that it wasn't able to be grown. And the second that Reagan got it, what happened? It all had to go even deeper. So if we make it accessible, I couldn't imagine, and I think about this all the time, the stress that Rick Doblin and any of us who are trying to advance this cause, the things that we have to deal with at night. I hear it all the time. Yeah, and fortunately, again, I get to walk 2 rows of corporate America and being president of a company. And I've had my sales guys have said, do you know why I came here? One, your voice is everywhere. There is no secret of where you stand. Like I've written books, I have a podcast. My LinkedIn picture is tattoos and a t-shirt. So I'm not a corporate. I don't wear a tie. Like I am who I am. And you either have to be okay with that or not. But a lot of people are still in the shadows. They're still hiding. And until we can get them out and let them know conversations like this and the amazing work that you're doing, and it's okay to not be okay, people are still going to continue to hide. We have to be able to meet them where they are to be able to at least root that out. At least that's my mission.
Thank you. Thank you. I'd love for you to share in closing, how, if you could kind of wave a wand, and see a system really blossom anew, and as we start to, see the old system come apart, we see signs of it already, with the assassination of the United Healthcare CEO, and you see this rising tide of people moving into action and taking steps. We see a lot of doctors getting out of the insurance system altogether, moving to concierge practices, moving to cash pay, lots of psychotherapists, again, out of the insurance hamster wheel, moving to cash pay. So we see signs already of things coming apart, but in your dream of dreams, like how would you love to see us recreate the system, and what can ordinary people do to kind of support this fresh perspective?
So I'll answer this a couple of ways. So I have been in the system for 30 years, but I always paid my premiums to Blue Cross, Cigna, United, being in a self-funded plan. I stopped this year. I actually couldn't. So I'm like, I can't really write a book about healthcare and continue to pay premiums. It doesn't make a lot of sense. So I have a friend who started a company. It's a crowdsourcing company called Crowd Health. So Crowd Health, you're basically with 40,000 other individuals and you pay $500 a month. That's it. And you pay the first $500 of all of your procedures, but it's on a cash pay. So you don't have to worry about where I go. So again, we went back to, if I could wave a wand, I would get rid of networks, because then the carriers really have no say. And then secondly, if you went back to an 80-20, or I paid the first $500, then it's it. I have skin in the game. I know what it costs. I'm not negotiating prices, and there's no hidden transparency or whatever. So Crowd Health, actually, you go in, they'll negotiate a cash price for you. I talk about this in my book. I had one of the most horrific stories I've ever shared is that I had an employer. He was the PHO, Physician Health Organization CEO. His wife needed a surgery. We were told it was $118,000. He got a phone call from the president of the hospital. And he said, hey, I just saw your wife's name on the list. If you just give me your American Express card for 14 grand, we'll call it a day. 116 to 14, credit card, anesthesia, hospital stay, all charges, done, 14 grand, because that's the cash price. So if you go in to see any provider and you say, I don't have insurance, they'll give you a cash price. It's typically 60 to 70% less than what it would be if you had insurance. Go back and bill your insurance company, get a copy of the receipt, and then send it. Unless you have a high deductible health plan, because the challenge you have with a high deductible is you're going to pay all of it upfront anyway, except that on a cash pay, you're going to pay less upfront. So cash pay. So what I would do, again, get rid of networks, get rid of the plan designs, go back to an 80-20 indemnity plan, and that you will start to immediately see competition. You'll see direct primary cares, you'll see cash pays, you'll see people in this space that will be able to survive and thrive. Same thing with mental health. We have to make mental health accessible. We have to make it affordable. So ketamine is another, again, classic example. So if we were to bring the cost of healthcare down by getting insurance companies out of the way, getting FDA regulations, and just saying, we know what the AMA guidelines are. We know the safety and efficacy, and we're just going to offer, and here's a cash pay price. You'll start to see that the rest of the SSRIs and all of the things that we know are bad, they're all going to go away because people will start gravitating by cost. Just because they're less expensive options, they're more willing to try other things that maybe are not so focused. So to me, those are three quick things. If I could wave a wand, that would address cost, not cost shift. It would actually lower the actual cost of healthcare.
Wonderful. Thank you. And I fully support his advice to ask for cash pay. You will be shocked across the board.
As I was thinking, I'm so sorry. I totally forgot one of the most pivotal ones. Fourth one is voluntary benefits. Now, everyone's heard about Aflac. And again, I've never really kind of thought about Aflac. It was kind of quirky. If you have a voluntary plan or from work, or you have access as an employee or a single person, get it. Because if you walk away from your health plan, this is actually what I did. I went to Crowd Health, and then I went and I filled everything with back policy. So I have an accident policy, having a 9 and 11-year-old. My daughter broke her wrist 2 years ago, needed surgery. I got a check for $2,500 for the surgery, but surgery only cost $2,500 with Crowd Health. So critical illness. So buy a $6 or $7 a month critical illness policy. So if something substantially happens in your ill, you get reimbursed by the voluntary benefit. Same thing with cancer. Cancer care policy. I know we think of them as extra things, but if you're going to walk away from the healthcare system and stop paying money to it, you got to have some layer of protection. And those are usually the best way. They're like $21 to $23 a month as opposed to what you're paying today.
That's fantastic advice. And so where would someone go to learn about those things? Because I think a lot of people out there have never even heard that those exist. Or if they have, they're like some vague nebulous thing and they don't really understand what it is they do.
So I would look for an Aflac rep. Aflac has them, Colonial has them. I mean, everyone in the insurance business that does like prepaid major medical will have those. I can give you some links so you can put them in the show notes of kind of where to look.
Yeah.
But that's what I did. I went to Voya, which it used to be ING, was a big bank, and then they changed their name and did new branding, but they do voluntary benefits. MetLife, we talked about in the beginning, Snoopy, they get out of the healthcare, but they have voluntary benefits. So a lot of these, that's kind of what's happened.
Fantastic advice. Wonderful. Thank you so much for joining us, Alan. Yeah. Is there anything else in closing that you would love to share? Any insights or go forward advice, inspo, and also where folks can find and follow you?
Yeah. So they can find me if you're on LinkedIn. So my name, Alan Wiederhold, very active on LinkedIn, Instagram, Facebook, TikTok, Alan Wiederhold. So AW Wiederhold is my name on everything. So super easy to find. I'll give you the copies of the show notes. My book's on Amazon. Number one in healthcare, which was crazy. But clearly I touched a nerve and I touched a point where people are of interest. We kind of talked about in the beginning, I'm actually helping some other friends. They have figured out a way to create an individual plan for members. And I'm helping them this afternoon to kind of create the risk profile around it. And they'll hopefully be out in the next couple of months. So they're aligned with our mission, Casey. They are so really wanting to build a healthcare program that gives back and tries not to profit. So obviously they're going to make a profit so that they're not insolvent, but they're not going to do so their mission is really awesome. I was talking to them yesterday and we were talking about ayahuasca journeys and things that we've done together and separated. It's just super amazing. They're great people.
I love it. One of the things I'm most excited about this coming year is there's going to be so much innovation and creativity, often just by necessity and frustration or having the knowledge of having worked in these systems and going, and I know everything that's wrong with them. Let me do it right with this knowledge. And so I think there's going to be so much beautiful creation ahead. And that's a great example of it.
I so agree. You. I questioned everything about things that had happened this year and being again at the psychedelic conference and then being approached by an insurance company. And it all happened for a reason, because that's exactly what you're saying. So it took Elon to transform cars. I'm not going to say I'm Elon, but it took an outsider to go into risk from a psychedelic perspective that I don't know I would have been able to have without my journey to really be able to blow up what I intend to blow up next year.
Love it. Love it. Thank you so much for being with us today.
Absolutely.
Thank you, everybody, for being here and listening. I highly recommend picking up this book. It is so eye-opening, so motivating, inspiring, and yeah, just deeply grateful for the opportunity to share. Thank you.
Thank you. Thank you.
All right. See you all back in a couple weeks. Thanks so much. Thank you for listening to the Microdosing for Healing podcast. Ready to take the next step? Please visit us online at microdosingforhealing.com. There you'll find lots of information about our global community, professional training programs, and upcoming immersions. See you there.